Oh, fun.
Now we're streaming live, it looks like.
Cool.
All right, there we go. Good evening and welcome to our Facebook Live series gearing up for the Endometriosis Summit. Tonight we have two amazing practitioners who are going to push the envelope a little bit and try to change our narrative, because that is our theme for the year. Go ahead, Frankie, why don't you go ahead and introduce yourself?
Yeah, so I'm Frankie. I feel that I'm a little bit different than most other people at the Endo Summit. I'm a sociologist and finishing a PhD at the University of Wisconsin-Madison, where I work largely in law, but I study menstruation and have recently have a study on trans and gender queer and non-binary menstruation. And I talk to people about gender and trans and intersex issues in clinical settings, in medical settings, also like improving and expanding care to folks in the LGBTQIA community.
Awesome. And Heather, why don't you go ahead and introduce yourself?
Hi, my name is Heather Edwards. I am a pelvic physical therapist, and I am also a sex educator and sex counselor. And I have a peculiar little hobby where I like to draw crotches for fun, and I like to turn them into all sorts of fantastical fun things, and play with anatomy so that, people who are engaging with them can kind of, have fun and imagine, different sorts of ways of being. And I also teach courses for pelvic physical therapists and pelvic health providers that are for education about trans and non-binary issues and how to be able to provide better care, more inclusive care. And I also teach courses on sex counseling for pelvic health providers as well.
Very awesome. For those of you that don't know, this is the coloring book. It's very crotch positive, but it will be our gift to you for attending the Endometriosis Summit workshop, and it is very, very awesome. I have a question. I think we would like to start just by talking a little bit about last week. In build up to this Facebook Live, we put up some posts about being more inclusive and using more inclusive language when it came to the body, and there was a lot of hate. So we're gonna own that. We're gonna own that hate comes from both sides of the fence, apparently at the Endometriosis Summit, but we're gonna talk about why inclusivity matters. So either Heather or Frankie, you can begin. Why is it important for us to change the narrative? That's our theme, change the narrative. Why is it crucial for us to change the narrative when it comes to gender and the binary and endometriosis?
Heather, do you want to go first?
Sure. Yeah. Okay. So I guess I always kind of like trip over this question a little bit, because I kind of don't really understand why we gender medicine anyway. So as far as like if we're talking about like vulvovaginal health or or reproductive health, like why we're assigning male or female to it to begin with, if because gender is up here, it's not what our genitals are. And so it seems, so to me, the whole uncoupling of gender and anatomy and physiology is kind of an important thing to just make sure that we're actually reaching out to everyone who's, who has a certain type of anatomy that is affected in a way, in this way. I mean, kind of the same thing with like cisgender men who have breast cancer and everything is, feminized. So so I'm always kind of one, like if you tell me that this solution is going to be good for 99% of the population, then I want to know what that experience is like for the other 1% and how we can make sure we're scooping them in also, because it kind of sucks to be left out and pushed to the margins. And so that's just kind of the way that I always approach it, is that like what are the ways that we can do this that's actually more accurate and make sure that we pull everyone in, as opposed to pushing people who are already marginalized out even further. And to me, it's not that hard, if we're just using like the anatomical terms, or the body, the referring to genitals, and instead of referring to gender, that, I don't know, it just kind of seems like it makes sense to me that way. And because you can be more specific, if I'm going to do a course that, or a class or something where I really want to work with people who have vaginas and vulvas and teach them about their anatomy, like I absolutely want anyone with a vagina and vulva to be there so that they can learn about all of the same stuff. And I also recognize that not everyone who has a vagina and a vulva identifies as a woman. And so that just kind of seems obvious to me that I don't want to exclude people with the anatomy.
I think it's really important. I'm old, and I too have made the mistake that like a uterus is female, whatever, and somebody said to me, it may have even been you, but somebody at some point said to me, an appendix isn't male or female, a gallbladder isn't male or female, and we have to take male or female or identifying anatomy as male or female away from it, because anatomy is anatomy. And that clicked and made so much sense. And it's right, because it's not fair. Not everybody that like if we're having an endometriosis conference, which we are in just about 2.5 weeks, we don't want to exclude. You're right. I want to talk about painful vaginal sex at the endometriosis conference. Not everybody that has painful vaginal sex is identifies as female, and you have to be because we started the endometriosis summit to be inclusive to all with endometriosis, and now we as an organization have to challenge ourselves to be inclusive to all. Yeah, very important. So Frankie, what is your take on all of this?
Great question. So as a feminist critique of science in general, all of science is coded and gendered. It's all socially constructed, like beginnings of what we thought was male and female in knowledge, or beginnings of stories that we tell about eggs and sperm, which, has a very gendered meaning to it, which now it's like, oh, actually the egg has more agency than we have always told the story. And everything does have gender and sex built into it. In our insurance, in healthcare, in diagrams, whatever. And so my participants and people that I talk to don't necessarily like advocate for specific uses of terminology from the medical community necessarily, which I love and is interesting. But there is an unbelievable amount of documented research that healthcare fails trans and intersex people, that the healthcare system is inadequate for them, and that people are no longer seeking healthcare because of the way that they're treated. And that's sort of a massive problem, but it's also against a lot of why people become doctors, is to help people in need. And there's a lot that's changing now with hormones and like also legal stuff about hormones and what people can and can't prescribe, and children versus adolescents versus adults. And I think that menstruation is really interesting because it is so highly gendered, and we think of it as so deeply associated with women, but not all women menstruate, and not all people with vaginas menstruate. And we have intersex folks, or folks who do align with our understanding of like XX chromosome, uterus, vagina, who don't menstruate. And we don't just like ignore all of those people and pretend that they don't exist. And so I think this is a great opportunity to invite people into healthcare, but also to talk about ways that we could maybe queer spaces to invite people in and also do better healthcare this way, and look at people's charts and look at how long they've been taking testosterone. Like, do you need to really ask them about their last period if they've been on T for so long? Just some understanding of the experience from the queer and trans intersex community who experience menstruation. So I think it's really important. And I love that we're having this conversation in the context of endometriosis. The people I talked to, I had several people who had different menstruation, either disorders or situations they were dealing with. And I was like, how do I put this in here and talk about disorders as, also people being trans? And I love that we can have this talk.
Mm-hmm. So why don't you, it's a good transition. Why don't you tell everybody about, you recently had an article published, very exciting. Why don't you tell everybody about your article before we begin? For those of you that don't know, Frankie will be headlining the Endometriosis Summit workshop where you'll get your crotch coloring book. But she will host one of the breakouts. It's not a breakout because we're all in the same room, but she will have a seminar in gender equality and in endometriosis and trans endometriosis. It's going to be very exciting. But tell us a little bit about your article.
Yeah, I got into, I have a paper on intersex studies, and I was into this idea of queering intimacy and also queering bodies, and menstruation kind of fell in my lap. And I thought, okay, I'm gonna talk about different living situations with menstruation. And I decided I didn't want to talk to heterosexual people because there's so much out there on heterosexual bodies and cisgender spaces. So I thought there's no research on menstruation in trans communities. There's discussion and talk, and there've been like social media movements. So I decided to do content analysis of social media and blogs and things that people were posting. And then I also interviewed more than 20 people, but some of them I ended up leaving out of the published study because they didn't have experience with menstruation. It was very hard to talk to people who had no experience with menstruation, although I wish I had more to talk about. But so I did a study, it was across the United States, about trans folks and their experience with menstruation and how it affects their concept of identity, how they navigate like period products and like the concept of period and like very feminized understandings of the world and how that might affect dysphoria. And I talked to them about bathroom spaces and like, where's the real danger? Because we have these bathroom conversations and people say, oh my gosh, like women's bathrooms are going to be treacherous spaces. And it's just untrue. The most treacherous spaces are in men's bathrooms for trans and queer folks. And then ultimately, everybody talked about healthcare and how the healthcare community via menstruation as like this mechanism for understanding their own gender was problematic. And there was a lot there. I could go more and more into healthcare as its own study, but it was it's a lot of interview, it's a lot of narratives, there's a lot of quotations and narratives from people, which I'm happy to share. But I think chiefly it just brought up a conversation of like, we can't always pretend that everything in science is so binary and we understand it textbook style, that we have social understandings of science and medicine. And people would say to me like, oh, I don't believe in it. I don't believe. And I'd be like, what don't you believe? There are people who identify and live their lives in gender, queer, non-binary spaces. And those people bleed out of their vagina. And we just are gonna not believe. I don't know what that means, but it was such an honor to also bring their stories and to do comics that I had an amazing artist, Jack Delaria, draw comics about the study so that they could be widely shared with people. And yeah, that's sort of the overview. The article was published last Tuesday. So yeah.
How do you think we can increase, it's good that you brought that up in your article, or Heather also, because you have a huge push in your professional life. How do you think we can increase safety in all our spaces within the endometriosis community for those who don't maybe identify with traditional binary?
Yeah, Heather, do you want to go ahead?
Yes. So, I think, we're talking about medical spaces?
Medical spaces, but also social media spaces. It's a big question. We could be here for half an hour, but social media spaces, in the online groups, also, in clinical spaces, and in, as at the end, I would love to talk about how someone can I think increase even safety in their own home about it. Many people are afraid to just be themselves when they have endometriosis in general because of the trauma associated with endometriosis. And then you have to take into account that there is so many issues trying to get care, and then to fall outside, or not outside, but to be different than gender norms makes it even more traumatizing. So overall, what can or what can we do as an organization, but what can we do as people in our everyday lives to increase safety within this community?
Yeah, that's a big question. So I know that we had a kind of a thread that came up about this in the trans and non-binary Facebook discussion group. Um, the it was in regards to bathroom safety in a clinic, and yeah, and it was tricky. I think one of the things that we, as we're talking about this too, that we kind of need to check in with a little bit is like understanding that as we're having these like worldwide discussions, right? Like on all of these social media groups, that like all of the countries we're in and that we're discussing from all have very, different policies and ideas of what's going on and which way like they're what's trying to be pushed and how. And for us in the US, like everything is so trans negative as far as like what's happening legislatively, that like it's really hard to step away from that. Yeah, I don't know, I just feel like sometimes that when we get into these discussions in online forums, that like we're not all talking from the same environment, and that can be kind of tricky. But as far as like bathroom safety, and I'm kind of talking about like US culture right now, because that's where we are right now, is, and it can certainly apply to many other countries as well, but is to just kind of like with bathroom safety, for example, there are a lot of really beautiful examples of ways that like you can have the sign outside the door, that has, that this is a non-binary bathroom, or that this is the women's room and, the men's room, but then a sign that says, please choose whichever bathroom feels safest to you. We are affirming of all gender identities here, and so lots of different ways, but making sure that it's addressed up front so that people can actually, understand what's going on and who they might see in the bathroom, and and so that's kind of like addressed up front. I think it's education, and it's just like this education that needs to happen like on a whole lot of levels, because it all flies in the face of like, in the US, there's so many messages coming in about like trans people are dangerous. It's, the trans, I don't even remember what the actual argument is, but it's, the women's rooms will be infiltrated with men in dresses, right? That are trying to be in there to abuse these poor women, right? Which is completely a false narrative. But, that's the thing that always gets pushed with bathroom bills and things like that. So, so as much as we can like kind of front load our education on, in our clinics and in our spaces, but then also like recognize that there's that difference between feeling unsafe and uncomfortable, and like recognizing when we're actually unsafe and when we're just uncomfortable, and what is it that is the source of our uncomfort or our discomfort, as opposed to just like, is it just because I've heard all of these things on the news and whatnot, and people are saying, and oh my gosh, now there's this person in the bathroom with me who does not seem as, as if they should be in here. And this is clearly a very unsafe position for me. When in reality, like you just said, was that, that it's not that actually the most dangerous people, or the bathrooms are most dangerous for non-binary and trans people. So yeah, so it's just kind of breaking all of those apart and busting myths and seeing all the different places that we can possibly educate people, both online and and in like in our bathrooms and our public settings and things like that. And those are just kind of a couple examples. And I think also making sure that all the discussion group rules that we have for like our online forums are already like automatically affirming, like, hey, in this group, we recognize that like trans women are women and that trans men are men, that, and we're not going to, that like misgendering people intentionally based on anatomy is not going to be an acceptable thing to do in here, so that the language has to be pushed a little bit further with that. So just kind of setting those standards from the beginning and not allowing people's gender identities or the like gender identity in general to be a subject of debate.
Yeah, I I was going to say that I think that healthcare and many systems in the world would be better off being informed by uh, trans scholarship, trans experiences. I think that including trans people of color in all of these discussions and narratives is imperative. I think understanding like layers of danger and identity are incredibly important for our understanding of the social world. I guess my one thought on bathrooms is that safety in bathrooms really would take a massive readjustment to masculinity, and it's happening, and it may be happening slowly, and it may have obstacles, but that readjustment needs to take place, honestly. I was going to say that there are other spaces where we could offer menstrual products generally. So like outside my office, there's a free box for anybody because period poverty is layered with trans and genderqueer experiences of menstruation. And so offering products that are free and also not gendered as strongly. And I saw visceral reactions when Always announced that they were putting out genderless packaging. And honestly, when I talk to also cisgender women, they say, I could do without that packaging too. So I don't know why that was such a big deal. But in clinics, in a healthcare setting, one of the dominant issues is that one or two people in a clinic may be trained to talk to folks of varying gender identities and may understand the use of different names and paying attention to people's pronouns and talking to people the way they want to be identified. So at this point, you may have like a doctor, perhaps a nurse, who is trained in this way. You don't have everybody in the whole facility, though, trained. And so from check-in all the way to check-out, there are spaces in which the gender identity training doesn't even matter, because if the person at checkout misgenders or calls somebody by their dead name, something they don't use, and then the nurse uses the correct, and then the doctor doesn't, right? There's like this whole train that people go through, and the medical community is an experience. It's not just a visit. And so it's really about holistically understanding the patient experience in a clinic and how it might be gendered. So there's, usually bathrooms and clinic spaces, and those certainly have gender, but there's also just like hallways, photographs, pamphlets, things like that. What you have on display is certainly symbolic, but also like if you ask on a form, and of course, forms could always use work, but if you ask on a form about someone's preferred name and pronouns and don't use it, it's hard to understand the purpose of the form in the first place. And so just having the form is not quite enough. There needs to be a commitment to understanding, integrating what's on the form into practice.
Right. So we at the Endometriosis Summit, I've made a lot of effort in our materials to always say people with endometriosis, because for probably 10 years of my career, I said women with endometriosis until someone pointed out to me just how marginalizing what I was doing was. But when that was pointed out to me, it also came in the context of when you have endometriosis, you go to the doctor a lot. And a lot of the times, regardless of any of this, you're very minimized in the first place. You're gaslit in the first place, and you're very minimized. Now, add to it that so many of the places are called, or so many, like we used to be called, Heather could get started on this one. We used to be called women's women's health therapists.
Section on women's health, yeah.
Right, section on women's health. I would go see a women's health physical therapist. And if somebody is non-binary, like they're like, I have to see a women, it's in addition to the trauma that exists in endometriosis, they're then being traumatized again. Or I've seen online, people I'm opening my new clinic, blah, 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 endometriosis and women's health center. And so like, I think that a safe environment begins on recognizing that even if you've chosen that name for some reason, you can put up language that's like, just like you were saying, like it may say women's bathroom, but feel free to put a sign underneath that says, choose what bathroom you need to, you want to be choosing. We actually talked to the W about doing that. And their answer to us was, we really don't care what bathroom anybody uses, but we're happy to put a sign out for you. But so I think in endometriosis, that happens a lot because the majority of the people who, it goes back to the majority of the people that get the disease have vaginas and bleed, and everybody associates that with being female. And so they open women's health centers. They have women's health physical therapists. And we've been working on changing that, because it's already hard to seek help and good help from in endo, and then to go through that makes it even worse. So like, I've had people say to me, you tell me to go into the section on women. Now they finally changed the name. I'm assuming it's active. But they go to the section on women's health website to find a physical therapist, and people are like, what? So it makes it really, really hard. Can you talk to me, Frankie, a little bit about, is there in your article, I think when we work with adolescents with endometriosis, there's so much shame about the period being so painful and many times so heavy, and it already creates like body image issues because of the bloating and everything else. Did you explore in your article what body image was like during menstruation in the trans crowd?
That's a great question. I talk to people about their first period experience, like first menstruation. And for some people that might be gender dysphoric. For some people, it might be confirmation that they did not align with the social expectations of their body. But there were people who certainly talked about layers of shame, like my body's betraying me. So first menstruation is like a betrayal. So additional factors of menstruation, and people talk to me about PCOS and endometriosis, that those things were like extra layers of shame, and also like scrutiny from the doctor's eyes, that like they were under scrutiny, under a microscope already, and highly medicalizing their bodies all the time was part of their trauma. And that could be the medicalization of gender dysphoria, and the history behind gender dysphoria and sort of where it is now, but also going to the doctor all the time as being, if going to the doctor, which it is so highly gendered, that we can't really escape gender in science. Actually, when I was hearing you talk, like there really isn't an equivalent of like men's health clinics. So health actually as a term, its default is about men. That's why we have women's health and female health, because the default is about men. Most medical literature is about able-bodied white men and their bodies. And we know in the canon of history so little about any kind of female anatomy, anything about this alignment, or intersex folks or trans bodies. And we actually aren't like keeping up at all. And it's evident, like we have these cases of like, women of color are dying in childbirth. And it's not because there's anything naturally wrong with them. It's because of the care they're receiving. And so we know that the social context of medicine needs to change. And medical schools and hospitals like all know this too. They've added sociology to their MCAT exam. Like they know that this is part of that. And I think that just understanding medicalized experiences in the context of the social constructs and also the social structures in which we live is really important, because it's exactly like you said, if we re-traumatize or continue to open, to have highly scrutinized medicalization for someone who is trying to come to know their body better, it doesn't happen like regular puberty, so the narrative might go. It's highly multifaceted, and we should be attuned to the fact that it will be different, and it will be different than dominant narratives of like your first period. I think that kind of answered your question.
Let's take a few minutes. My favorite. Let's talk about sex a little bit. First of all, Heather, can you tell everybody what Vino and Vulvas is?
Sure. Yeah. So, so I mentioned that I'm a sex educator and a sex counselor. I actually did my ASEX certification, which is the American Association of Sex Educators, counselors and therapists. So many words in a row there. But yeah, so as part of like the sex education I do this adult sex ed in a bar. And so we basically put together a panel. I usually host it, and I put together a panel of 3 professionals, mostly professionals. And so we cover everything from like, our last one was how to rock a threesome. And then like we're doing sex positive families in a sex negative world. And then we'll have one on sex work is real work. And then we'll have one that's beer and buttholes here in a little bit, where the great thing about all of these, and especially the beer and buttholes one, is like we always have like a medical professional and a mental health professional, and then usually we'll have someone else, like we'll have like a comic book artist, Tikva Wolf, who does polyamory comics, and we've got Natasha Knightley, who is one of our famous drag queens in town here, and burlesque dancers and things like that. And so we get everyone all on the stage together to have these conversations. And so there's all sorts of like fun and flair and craziness with them. But then we're also like making sure that everyone understands how to have like the best poop of their life by the end of the show, you know? So, so we kind of blend fun, crazy, kinky stuff with like, you know, knowing how your internal anal sphincter works and whatnot. So
Heather once, it was probably in one of the groups, said that she begins each session sort of with which she's a physical therapist as well, and she begins each session with a disclosure to her patients that they can tell her anything. Do you want to share, like you have a very specific way of saying it. Do you want to share how you say that?
Yeah, and this actually, I was kind of writing a note here a second ago. It goes a lot to the changing the narrative, right? So the way that when I think of changing the narrative, a lot of what I do is I try to like not assume a narrative. So like there's no narrative in the room that needs to be changed, I guess. So allowing someone to build their story from the bottom up so that I'm not having to like assume something and then they have to sit there and decide whether or not they're going to come out about it or not, you know. And just kind of a note, because you know, as we're talking about all this stuff, we're talking about it, you know, related to, you know, trans, non-binary and intersex individuals. But the thing is, like, this really, like, having everything be pink and women's health and flowery and whatnot, that's not really good practice for cisgender women either. You know, I mean, cisgender women come in all sorts of varieties of who they are, what they feel like. And so I just feel like that when we genderize medicine, we're just forcing everyone into a narrative that is assumed upon them. And so I like to kind of bust free of that. And so the way that I kind of will, you know, have someone come in and they'll tell me like their basic story of why they're there. And then I'll say, okay, you know, and I'm a pelvic physical therapist and a sex counselor. And so now I'm going to kind of go through and get a little bit more detailed, but I just want you to know that as we're in this room, you know, absolutely anything that is true about you can be true in here. So regardless of any gender things, orientation things, I said, well, I'll be asking you some questions about sex. If if you have multiple partners, or if there are some crazy things you like to do with your body, you know, whatever that's all fine. All of that can be part of what we talk about in here. You won't get any judgment or shame from me. And so moving forward from there, then the history is all of a sudden a lot easier, because, you know, even with things like pregnancy, right? Like if we're asking, well, you know, have you had any children, right? Like those questions, when we start there, is already assuming a narrative, right?
Right.
You know, and so just making sure I start with like, you know, have you ever been pregnant? You know, is a place to start, as opposed to that, because that narrative from that question can go anywhere, you know, but it's just starting with like the most kind of foundational places for people to be. So, and, you know, and the same thing when we talk about like sexual history, you know, like making sure it's not just I don't know that people actually ask just, are you sexually active anymore? I know early in my career, I got myself in so many troubles, so much trouble asking that question and then not following up appropriately. And then like realizing things later on, that's like, oh, wow. Yeah. So I would read you the way that I asked all of that, because that didn't give me the information I needed. But
I think in endometriosis, it becomes really important that to create it, at least as a physical therapist, because you're getting an hour with the patient, or the person rather. And it becomes really important that whatever somebody chooses to do consensually with a partner is whatever somebody chooses to do, because it does impact, like endometriosis lays down in the rectovaginal septum. Many people think that only causes pain during like penetrative sex, but there are people who have sex in many, many different ways. And so understanding what hurts or what doesn't feel good to them not only can help with the physical therapy, but it also can help very much when the physical therapist works with the surgeon. And we had a few examples of that within the last month of just how, if we had not created an open environment for the person to share everything that may or may not have hurt, then it could have been disease might have gotten missed when they chose to go through surgery. And so creating that environment, it definitely in endometriosis has a huge impact. And unfortunately, I've also, running the summit, I get lots of calls. And I got a call from someone who was, and she was very open about it, but she was a Black lesbian who was told that her endometriosis meant nothing. I'm going to get your comments on this in a minute. That her endometriosis meant nothing because she wasn't playing for the other team. And when she seriously, it happened, like she says, within the last 5 years. And that unless she wanted to take birth control for no reason because she was a lesbian, she didn't, the doctor kept saying, you really don't need it, that there was nothing they could do for her. And I almost cried from the phone call. And I think, like, when we look away, I live in a major metropolitan area, but when I talk to people from all over, these are the phone calls I get, and they make me really sad. What do you have an opinion on and this has gone on in endometriosis for a long time. Like, I've had people who identify as lesbians tell me that their doctor said, well, it didn't matter because they don't have sex the right way, as if there's a right or wrong way to have sex, that they're not having babies anyway, so what do they care if they're infertile? Not to mention endometriosis causes horrible pain. Like, this goes on a daily basis to a lot of people. So, where do we all begin with that?
It's changing the narrative that women's bodies are to be used for the purpose of men. I mean, that's what that is, right?
Actually, what was interesting is most of them say the worst is female doctors.
Right. So so patriarchy, right? It does not mean men are doing the work of patriarchy. Any genders, can be promoting that same story, right? And that same narrative. So yeah.
We have someone right now who just commented that they're a lesbian and they're being told the exact same story, and their doctor, it says their primary laughs in her face when she asked for specialist referrals for endometriosis. Frankie, what was it like, or Heather, what is your experience like in people trying to seek care when they, in this case, this discussion, we're talking about lesbians try to seek care for painful sex?
Yeah, this is a great question. And it's certainly part of sexual scripts and our understanding of very much like penile vaginal sex and its pleasure. I saw an article posted in the last 2 years that doubted the ability for clitoral orgasms. And I'm sort of wondering where we're at as a community. So there is evidence that people in the LGBTQIA community use birth control, and that they get abortions, and that they seek care just like everybody else. And understanding that sexuality is not one or the other, and that it has this identity that matches all behavior is really important. But when there's a general distrust of the medical community, so certainly women and people of color have a massive distrust of the medical community, and they should. They have a long history of being tested on with birth control products. The US government also not caring about their sterilization or putting out products that they knew would be harmful, like the Delkin Shield, that kind of thing. And also experiments on like STI experiments on Black men. Like, there's a long history there. And there's there's also a history of horrible medicalization of gay, lesbian, bi, trans, intersex people, where people are so misinformed that they're falling back on the sexual scripts they grew up with in the world they're part of. And if they never have the social frames or the recalibration of their thinking, then they're practicing poor medicine because they're not addressing the person in front of them at all. They're addressing their conception of sexuality, gender, and like their own space and their own opinion, rather than research-informed, data-based, trans, intersex, people of color informed medicine, which is what we need if we're going to see people for endometriosis and be able to help them and perhaps like help them live a better life. We need to be understanding the person, like the whole person that is before us. And we're not doing that, and we're not doing it well. You know, there's lots of little communities too, between like Reddit and the internet and online posting boards, which is where I do some of my research. People talking about queer friendly doctors in their spaces, that people sort of set up these almost like survival networks of like who to go to, who, you know, may not necessarily agree, but will prescribe you a certain medicine, or who is going to be cool about having a conversation with you about testosterone, who's willing to put in 2 years of time for talking about menstruation and gender and be your primary care. And endometriosis has kind of had a pattern like that, that women will use like online spaces to communicate with each other. And if every doctor who treats any kind of woman ever or person looked at the online conversations happening with thousands of people about their experiences in their clinics, I think that medicine would really change.
Yeah, I mean, it's interesting because we notice in the endometriosis community that while the doctors are realizing the money in the social media communities that are out there, and so they'll placate to those communities. But what we really notice is now, like, pharma always wants to lurk so they can customize their ad campaigns to try to draw people in, because people are so drawn into the online communities for endometriosis. I just had to throw my shtick in there a little bit about that. But I'm curious, Heather, if you want to talk a little bit about painful sex within the lesbian community, because even now we get comments like endometriosis only hurts further back, and it depends. I've taken some comments down already, and it depends how you're having sex. And like, this is the thing, endometriosis causes painful sex. Rectovaginal endometriosis does tend to cause pain at full penetration, but who knows or who cares how sex is being had between two consensual partners, regardless of anything that goes on. But as a physical therapist, I was wondering if you wanted to comment.
Yeah, I mean, I don't think I have anything profound to say on this past, like, everyone has the right to do with their body whatever the heck they want to do. And so, like, I'm not, and I don't feel as if it's my job or anyone else's job to gatekeep what someone, the way that someone has sex. Like, you know, so as far as like it being like, I don't, and because I don't even particularly care what orientation someone is when they come in to see me. All I want to know is, you know, like, okay, so what is it, you know, what's bothering you? And, you know, when we're talking about sex, what are the things that you like to be able to do with your body, you know, and like what sort of things, if it's penetration, like what sort of things are you generally, you know, are you doing penetration? Are you being penetrated? What sort of things are you being penetrated with? You know, are you having any difficulty? What's causing distress for you? You know, like all of that. And so, like, I don't,
Right.
anyone could do anything. Right. Yeah.
Right.
So like, so it's not, I don't ever say and I would have the same exact talk for, you know, someone who's a cisgender male, because like I've had multiple times where, you know, you just open up the field like that. And, you know, this, you know, straight cisgender man who's married, you know, in a heterosexual marriage and, you know, all of this will then start telling me about how much he likes to use really huge butt plugs and, you know, has enjoyed having anal sex with men every so often as well, you know, but you know, it's like, so it's like, it's anyone has the right to do anything with their bodies. And I am there to support whatever their goals are for that. So,
Right.
yeah.
I was going to say that the sex and disability community is probably like the best outlet for the answer to some of these questions. That even in our understanding of like lesbian culture, most people who watch lesbian pornography are like men between 35 and 45. Like what we think of as narratives is always about penetration, and it's always about depth,
Right.
and the toys look that way, and they're like, ribbed and designed in very male type of
Right.
spaces. And there's so few, honestly, like genderqueer, gender neutral sex toys out there that are not necessarily meant to mock any gender or sort of like imitate a sex category or any kind of genitalia. There's so few, and they're really interesting though. But I was going to say that the sexual scripts that we start out with and all the way to, through the life course has so much to do with penetration and this like normalization of, well, penetrative is best, or that even vaginal penis engagement is best, when intimacy and sex doesn't always have to be that way, that people have intimate experiences that vary greatly. And the idea that penetration is just like it, or is like the option rather than an option, is I think problematic. That if people understood how much intimacy is so much more than that, people would be having better sex. First of all, there's a reason that lesbian women report having the best sex, and why women who like female in like heterosexual couples, females dating males, they would report similar sexual satisfaction. And they would be like, and people would say, Frankie, look, like men and women are equally sexually satisfied. Put that in your shoe. But sexual satisfaction was very different from male to female. So for males, sexual satisfaction is typically, did I ejaculate? Did I come? And for females, often the rate of satisfaction was, did I make it through this encounter without pain? And those are two very different descriptions of pleasure and satisfaction that we should be paying attention to. And if it has to do with like masculinity and social scripts about how people have sex, we should probably let those go at the door, especially as a medical community, and learn a little bit more about other ways that people can be intimate, and like other ways that people want to experience intimacy, but also like sort of turning some of those narratives on their head, and then maybe being a little more innovative with sex and intimacy overall.
Yeah. When I have people come in, that's like often, because often the goals are they're coming in because of a penetrative issue, right? Like that's what brought them in to see us. And so I feel like our job is to, one, discuss like the hows and the whys and the whats of why they want what they want, what sort of distress they have around it, and then teach them that piece of the whole reason they're there is just a tiny little slice of the pie. And I want to teach them what their whole pie actually is. And and so it's just that, like, open their eyes to be able to see so many more options. And even if it's just the same thing that they've been doing, to be able to understand like the different energetics that can go along with it, like how they can play with their own empowerment, and the reaction and the responses that they're getting with one another, and just how they can communicate better to get more out of what they want, even if they're continuing to go back and doing the same thing that they've been doing the whole time. There's just so much about it. It's queering the script, as you said.
Yeah, I think even the language people use to talk about pelvic pain matters a lot in terms of finding their whole pie. I like the way that you said that. But I'm going to shift gears a little bit because we're sort of rounding out our hour together. Frankie, last year, Corey came. He's a big trans and endo advocate. And he talked a lot about how difficult it was for him to receive care because he had already had a hysterectomy as part of his transition. And so everybody insisted he didn't I believe that's the story. I really hope now I'm not quoting it wrong. But and nobody believed that he could have endometriosis as someone who's transitioned already. Did you come across any stories like that in your research?
I have stories of people who take testosterone, and then interestingly, either doctors don't care or don't take into account they've taken testosterone, or because someone has taken testosterone, they then deny them other kinds of care for their bodies.
Right.
So yes, absolutely. And we know so little about how hormones affect bodies and what they do. And like people would say, I wish my doctor could give me sort of a time frame of when would my period stop? Like when would the bleeding stop when I started when I started testosterone? And it's like, we don't have a lot of literature, we don't have a lot of research, and so again, I think the impulse is to answer a question and be like, well, I have the answer because I've seen lots of people with endometriosis, like I know how this works. But we actually don't have data and we don't have research on trans and intersex folks and endometriosis, and so to acknowledge that there isn't a lot of information and research would be such a huge step, but to also encourage people to keep fighting and also to like keep accessing their bodies and accessing healthcare, and like, yes, not to give up, but also like accessing medicine through like communities rather than going to just your standard clinic. There's also an issue with what you just brought up with like insurance. So insurance is certainly sex coded binary, and it has to do with birth certificates, but also just insurance companies and employers and gender identity. And so people cannot access great care if they have different codes insurance wise on procedures they've had before, what their sex gender identity is according to the company. So they can't receive certain medical care. And it would be a hell of a step if the medical community would start fighting for those procedures, those rights, and that acknowledgement from insurance companies, because that would change the game instrumentally if there were more doctors and health professionals who were advocating for their genderqueer, non-binary patients.
Yeah, well, coding in general is a big
Oh.
issue. I'm sure if you go to the Endometriosis Summit, you will begin to understand that. Yeah. So as we, what would you like to share about endometriosis and this topic? Either of you.
I have
Yeah.
a comment that, so this was just kind of an observation that I've kind of, I think had like a lot this year, because I've been teaching with a mental health professional, and we've been going around and teaching medical professionals basically. And it all of a sudden dawned on us after kind of seeing the feedback that we would get, and because a lot of the things we were doing were, I think, challenging to some of the medical professionals, as far as like kind of suggesting that maybe they didn't know as much as they thought they did about some of these things that are more challenging. And one of the things that you're just talking about, like the narrative, and talking about the ways that medical professionals could do better, is mental health providers, they kind of know that when they work with a client, that they bring all of their own baggage into the room with them, because it is just a part of who they are, right? And so in order to be able to, work with that person in front of you, you need to be working on your own stuff and understand what your trauma responses are, and understand what your triggers are, and understand like kind of where you, and then if you are having an issue or a challenge, like know that you need to go and reach out. They call it supervision, right? So they, reach out to their supervisor, or reach out to peer consultants or things like that. And I feel like in medical health, like we are pretty much taught that like we are able to go into a room, and it is unprofessional to bring any of our baggage with us. So we just leave that behind, and then we are absolutely objective, and we treat everyone kindly and the same and to the best of our abilities. And I think that that narrative that we have, like that belief of like who we are and what we're doing, and that our personal thoughts about gender and sexuality and and orientation and pain even, and and like what are our feelings about all of those things, that stuff really really matters. And you can't treat that person in front of you if you haven't actually examined your own like responses with all of that. And I don't know, I just felt like I wanted to kind of throw that in, because I feel like that's one of the things, like one of our sort of uphill battles for the medical field, is like understanding that we are not actually like objective professionals in a room with someone else, and we got to be putting in the work to understand how to step it up and be better.
right? Also with, you know, endometriosis at its core is pretty much chronic pain.
Hmm.
And physical
Right.
therapists, now my close friend is a social worker, so I'm well aware of this concept. But so like I live in, I have endometriosis, I work in endometriosis, I socialize in endometriosis, like, and so the concept that we need to explore what our triggers are, because you can't be, you might be able to be there for a patient or patients for 6 months, but you
Mhm.
won't still be standing 10 years from now, because you'll either hate them or you'll hate yourself. And it's sort of like the same concept, like you have to explore your own triggers in order to be a good provider. It's funny because my friends are social workers, I just assume that that's how it is. It doesn't
Mhm.
always occur to me that that's not how it is in the rest of physical therapy, but it's
Mhm.
super important to get that. I really hope, Heather, we'll have to have you at the summit next year. Maybe we'll let you do a whole workshop. We'll let you do
Uh,
beer and butts,
beer and buttholes. Yeah.
beer and buttholes in the middle of the end. Maybe not, but we'll let you do something fun.
Depends on what kind of hate
Well,
mail
we
you
could
want,
do an
right?
evening, Vino and vulvas. We could do a social event
A
somehow. We'll have
social.
to think about it.
All right.
But Frankie, why don't you tell everybody a little bit about what your workshop is going to entail? Before you leave, I do have to tell you that we are at the Endometriosis Summit workshop, which is sold out. We're about a 60-40 split, which is 60% physical therapists in that workshop, but 40% patients. So you got to really bring very interesting stuff to us.
Yeah.
Okay, I promise to try. The pressure is on. Um, I um, I think that there's a little bit that we alluded to here about layers of stigma and experience. Also, I was thinking mostly about in this context, fat bodies, disability, people of color experiencing endometriosis in way different ways than even the narrative of endometriosis, which I think is very interesting and should definitely be tackled. We know almost nothing about menstruation and endometriosis in communities of color. I'm doing an audit study right now on the medical community and studies including people of color. Pretty much nothing. That the paper will say that. And I want to bring those discussions in and also have people ask themselves what they could be doing better in their communities or what they could be changing in their workspaces or perhaps their lives, or what possible solutions there might be. I want it to feel workshopy in that way. But I want to be able to share narratives of people who talked to me about accessing healthcare as menstruators and as people suffering with endometriosis. And I want to talk a little bit honestly about just like sex and gender in healthcare spaces. So I'm hoping that it has this like overview, a little like sampler platter for everybody. That being said, I have, given this presentation to different groups. So I'm going to run it all by my team of plastic surgeons who I work with. And so see what they have to say as well. But I'm just excited, I'm excited to have the conversation with people.
Yeah, it's interesting you bring up. I feel in the endometriosis community, there is fat. I mean, in everything, there's fat shaming,
Yeah.
but I get so many people who, if you lost weight, your pain would go away. I get so many, it's because you're overweight that you have pain, which I didn't notice that pain and fat go together. I mean, I recently lost 35 pounds. I'm not sure that pain and fat went together. The other thing is that we also get it the other way in women that are, and people that are very, very thin. They say, well, if you gained weight, if you started eating, but here they have bowel endometriosis and they're not digesting any food. So how can they gain? I mean, there's a lot of shaming at every single level that goes on. So it's interesting that you bring that up. All right, I am going to challenge the three of you. You have, or the two of you. We are going to, because you changed a lot of things while I'm sitting here thinking. We have a panel called the Sex and Relationship Ramble. And it's very cool because it's interactive. And I'm sorry, it's interactive. And if you want to send me questions, that might challenge what people think. They have to be yes, no, or maybe questions, because we're going to have our audience dance. Like if it's one is yes, then they have to do one thing. If one is no, they have to do another thing. If it's maybe, they do one. We're going to have them run around the room, but we sold too many tickets. So if there are questions you think will challenge our audience, you can send them to me, email or PM, and I would love that.
So yes, no, or maybe questions about sexuality and relationships.
Right, because you guys think so far out of the box that like my box is too small. I mean, maybe that's a problem, but my box is too small. And so it's time to push the envelope. And if I don't push the envelope in every panel, then I haven't done it justice. Like, it was a big deal to me. I didn't want to have a trans and endo panel because it shouldn't just be about one panel this year. I wanted to incorporate in every single way. So I ask for help humbly. Anyway, thank you for joining me. Any parting thoughts?
I'm just excited. Like I just get excited, and I'm like, I think mostly in my head, I'm thinking, okay, if we come to these conversations with this very like, what do you know? What do I know? How do we like put those things together to build rather than to like challenge or to argue or to like dismantle? Like, how cool would that be? Like, if we all had this very like functionalist version of we all work together with different experiences and knowledges. So
right.
I'm very excited.
I think Hoboken is a great place to do that. Because it's just a city like that. I mean, I am very excited we made it. And so many people, Heather, have come to me and been like, I'm going to donate something for the workshop. And I'm like, no, because the only gift people are getting is the coloring book, because I feel that it pushes the envelope just a little bit. And so next week, my lovelies, we will have Dr. Cernova will be here from the Center for Endometriosis Care in Atlanta with Dr. Vidali. We will talk bowel endometriosis, and we will talk lung and thoracic endometriosis, a total shift from this. Somebody really needs to reach me. A total shift from this evening, but we will see you back here next Monday night. Thank you for coming.
Thank you.
Thank you. Good luck with the conference.
Thanks. Take care. Thank you for everything.
Thanks.